this mic work also? Can you guys hear me with this one? So I thought before I would begin this session, one of the other things that Chris didn't tell you, I love history, and I also enjoy storytelling, so you guys are probably in trouble. But I thought I would take you back because this is a famous area for pirates, and if you can imagine, in the 1750s, the coast of West Florida was uninhabitable. There was mangroves and bushes. It was impossible to navigate, and it was kind of inhabited only by the Calusa Indians that had a lot of tribes along these waters of Tampa Bay, and Tampa was actually named from a Calusa word. So in that time period, there was a famous, maybe, it's either myth, legend, or story, but there was a famous pirate named Jose Gaspar. And you guys know that because today we celebrate Jose Gaspar by getting incredibly drunk and having too much fun. So I thought I'd tell you where the legend comes from. So in the 1770s, this was the second Spanish kind of reign in the New World. Gaspar was believed to have been an admiral in the Spanish Navy. And as an admiral, he had actually stolen the crown jewels and had escaped from the rest of the Spanish Armada into the coastal waters of Florida where he began his piracy. And he was very effective, and either you would join Jose Gaspar or you would be put to death. So in the pirate world, there wasn't really an and or if or but, you just had to do. So all of these pirates would hide in the little inlets and bayous and bays of the west coast of Florida, trying to stay away from the Spanish ships and the British ships that were going back and forth between Mexico and Europe. So one of the most famous stories, and you guys might know this story or you may not, was when Gaspar captured a Spanish ship, and on that ship was Giuseppa, who was a very beautiful Spanish woman who Gaspar fell madly in love with, and he would advance on her and would try to have her marry him, but she kept refusing. She said she would rather die than accept him as her husband. And so the crew gave him such a tough time that he was such a weak man for not convincing this woman that ultimately they beheaded poor Giuseppa and threw her body over the side of the ship. And some believe that was where Giuseppa Key is now, and the Giuseppa Key was named after this Spanish princess. So finally, Jose Gaspar got tired of being a pirate because it was a lot of work and there was always people chasing him. So he figured he'd one last time go after a merchant ship and then he would retire into the New World. So he saw a ship off the coast of Florida. It looked like a merchant ship, but when he ran upon the ship, an American flag came up, and at that point, Spain had turned over the territorial waters to the U.S. Navy. That was USS Enterprise. And the Enterprise bore down on this pirate ship and was riddling it with cannonballs and all kinds of metal, because they would basically take the cannons, in addition to the cannonball, they would take spikes and other metal and pack it in. So when these things would blast the decks of the ships, not only would the cannonball and the grape shot come through, but bits of metal, spikes, and other stuff would riddle the crew. Finally, Jose Gaspar didn't want to be taken by the Americans. He tied an anchor to himself and dove into the water, never to be seen again. So in case you're wondering about Jose Gaspar, that's my story about Jose Gaspar to start this session. But I think now we'll get back to doing orthopedics. All right, so one of the things I wanted to kind of bring up today was these proximal humerus fractures. And so let's talk about anatomy. So to understand why you get these fractures, you have to understand the anatomy. And there's 4 rotator cuff muscles, there's a deltoid muscle and a pec, and they tend to displace this fracture. So to have a 4-part fracture, you usually do not have a rotator cuff tear. So the greater tuberosity is always pulled off and it goes posterior, the head breaks, and so we have these fractures and you can kind of predict where they're going to go. And these are the forces that are in place when these occur. It's a bimodal fracture, meaning it's either someone who is my son's age riding a motorcycle or doing something crazy that runs into a tree, or B, it's a 60-year-old female who falls down walking on a hiking trail. And so there's this bimodal kind of curve for proximal humerus fractures. When I was a resident, we kind of thought that the blood supply came from the vessels in the front of the shoulder, the anterior circumflex artery, and that went to the head, and that if that got damaged, you'd get avascular necrosis and the ball would die and it would be awful, but that really doesn't happen. In most cases, even if you get avascular necrosis, the fracture is still very viable, it heals, and patients can do relatively well. There's a problem in that we've been trained as orthopedic surgeons, and when we go through our training periods, we learn how to use plates and screws and to do arthroplasties to fix these, and probably we over-indicate surgery. I hate to say that, I like doing surgery, but we probably over-indicate surgical treatment of these fractures. And we thought in the early 2000s that this locked plate that came out would be a panacea and we would have this problem licked, and we really don't. And there's very few studies that tell us whether surgical treatment is better than non-surgical treatment. Just this past month in the Journal of Shoulder and Elbow Surgery, this article came out. So this is at the Hawkins Clinic in North Carolina, or South Carolina in Greenville, where Chris hails from. So patients come in, and Chris or one of his colleagues, Dr. Kissenberth or Dr. Tolan or the people who work at this clinic would tell the patient, this is a 3 or 4 part fracture, you're 70 years old, you need to have a reverse shoulder. Well, some of the patients said, okay, and they had a reverse shoulder, and other patients declined to have surgery. When we actually looked at the final results, so the group that said, no, I'd rather not, Dr. Tolan, have surgery, I'd rather let this heal up on its own, there was absolutely no difference in those two groups. These are people that the surgeon thought would benefit from an operation. So non-operative treatment was just as good. There are only really 3 randomized controlled studies in the entire orthopedic literature, and I can tell you there's over 1,000 proximal humerus papers that have looked at operative and non-operative treatment. One is from Scandinavia, and in that one, really no difference. The other one is also from Scandinavia, and finally there's a Proffer study that was in JAMA, and there's some flaws with the Proffer study. This is 2-part surgical neck fractures, but these studies said that if you really randomize these people, and it wasn't done quite that well, but it was well enough to tell me that we have to really, really decide who will benefit from surgical treatment, especially in elderly patients. So I'll give you some case examples of my own. So this has changed my practice. I can tell you when I first got out, I probably operated on more people than I do now. And one of the things that you learn as you do this is it is really an art for medicine and picking the right patient for the operation. And I've failed many times, and so hopefully I can kind of give you some of my advice or thoughts or musing on these kind of problems. So this is a 78-year-old. Right away, 78 years old. So I think about when I'm 78 years old, what do I want to have done for me? And she's already had diabetes and heart failure. Well, we know diabetics don't do very well, especially if they don't have good control. So you can almost say that if your hemoglobin A1C is off the charts and you're not controlling your diabetes, probably not a great candidate for a surgical procedure. So this was her fracture, right? And there are some people in this room who probably would say, yeah, you can fix this. And I wouldn't disagree with you. I mean, you can look at this and say, okay, maybe we fix this. And, but we treated her non-operatively because of her comorbidities. And this eventually healed, and that x-ray doesn't look very pretty, but if you look at her in the clinic, she has no pain, and this is her range of motion. And that's the thing you have to remember. What is our end game? And if you look at the results of internal fixation, oftentimes they don't have that. Oh. Excuse me. We had a little technical glitch. All right, so this is an 89-year-old female. And actually, this lady's son was one of my patients. I fixed his rotator cuff, and so he brought his mom to me. And she came in, and she had this fracture, which is, as you can see, it's kind of a comminuted fracture of the humeral shaft. And we treated this one in a Sarmiento brace. And if you look at it, you can see the shaft and the head, right here. It's not completely spot on, right? I mean, but if this fracture heals in this, 89-year-old female, I mean, I don't think I can, I hope the thing stays in the right spot this time, but I don't think I can make her any better than this. So again, using a Sarmiento brace is probably an excellent choice in an 89-year-old female. We'll have to talk to those guys. All right, so the next one is an 82-year-old retired male who had a ground level fall, and he has some swelling, and he has COPD. So this guy comes into clinic, and I don't know if you guys see these people that come in, they have their little oxygen bottle, and they got the little plastic thing, and they're having some trouble breathing. And so he had this, and this is 17 days after injury. We let that heal at 10 months, and he did very well. So what is the problem with surgery? Well, the problem with surgery is that we don't like to see x-rays like this. This means you need a second surgery. So the first surgery fails, and now you have the privilege of having a second operation. Now that is great if you're the surgeon, if you want to do a lot of surgery, but not really great for the patient. And so this is my success. I didn't block him out, but you have to look at, so I think after doing this long enough, there are certain things you have to look for in your patients. And when someone sends me someone from a nursing home who is bedridden, I'm not going to operate on that person. There's no point in having a 92-year-old lady come to my clinic who's in a nursing home, because we're going to treat that conservatively in a sling. So if you look at hemoglobin A1C that's off the charts, it's out of control. They're not managing their diabetes. They're not going to manage a fracture. If you look at alcoholics, most alcoholics I have ever operated on, I have regretted. If someone comes to clinic drunk, that is not a surgical candidate. And you think I'm kidding, but that happens. And I got fooled like once or twice. So, I mean, where I thought this guy seems really reasonable, and they come back and the pins, I'd pinned somebody about a decade ago. Pins are in the sling, he's drunk, he's having a great old time, feels great, don't need the sling. I mean, these are the problems you have. So you have to really judge people for what kind of comorbidities they have. Demented patients don't do well with surgery. Don't operate on demented, especially on the proximal humerus, because it's going to heal. So how do we get this right? Well, I think if you look at this, there's the deforming forces. You have to reduce the calcar. So that's, when we say calcar, we're talking about this area right here. And you can impact the shaft into the head, or you can graft that to do this. And so if you don't get the calcar reduced, the ball will fall off like that. And so we want to get these screws really low. So we need to have really, really good fixation. And so you can imagine younger patients have better bone. So bone quality matters. So if you have a 42-year-old who wrecks his motorcycle, you can get great reduction on him. He may be a great surgical candidate. So when I'm looking at these, I have to really think about who I'm going to help. So we have created our own problem. One of the most awful complications that can occur is when the humeral head collapses down on that bed of nails, and then they poke through and they grate into the glenoid. And that destroys the glenoid. That's something that we created as orthopedic surgeons. That didn't exist until we had these locked plates, and so that is a big problem. So what we want to do is cascade those screws, have the calcar screws longer, provisional reduction with K-wires, and this is kind of what we do when we do surgery. So I do this with a C-arm, which is an X-ray machine. You know, I want to see all the screws going in. I want to make sure I have excellent fixation of the fracture. This is kind of an idealized version. So now we've decided to do surgery, so what we want to do is handle the soft tissues with care. So what I like to do is put heavy sutures into the muscles, into the subscapularis tendon, into the supraspinatus tendon. These act like reins on a horse. So now I can control these fragments, I can move them to where I want to, so I can get this fracture reduced, so I can temporarily hold it. So I use these very long K-wires to hold my fracture, so I can get an X-ray and make sure I like it, I like where the reduction is, and that this fracture looks really good. So we did this and looked at our patients, and so this is what I did with my former fellow, Dr. Brian Babman, who's in Indiana. We looked back at how we did at these, and basically, if we stuck to our principles, very, very crystal clear who was not a good candidate, and that's the toughest part of this, is picking the right patient, that we could achieve tuberosity union and no failures of the tuberosity. So we had fracture healing and anatomic alignment in 72%. So I think in treatment, if you're over 75, you have to think long and hard about doing an operation, whether that be an arthroplasty or a plating. So when you guys are out there and you see patients who are over 75, sometimes sending them to the orthopedic surgeon may be the worst thing you can do, because there are a lot of people out there who will operate those patients, and then they have complications. And that's what I really want to try to avoid. Now, sometimes you have the ball is dislocated out of the socket and you're forced to, but I think that we have to be really judicious in who we operate on after the age of 75. We could talk about the reverse a little bit. You know, patients ask about it. You know, they're educated. I have people come in all the time. They say, hey, can you tell me about this reverse shoulder I was studying? And the other thing I don't like is now they know what I look like. So when the fellow goes in first, they go, you're not Dr. Mile. I used to get away with that. Now they're like waiting for me. So I think that the computer's been a great thing, but it's overeducated our patients. So the reverse is probably something that you want to do as opposed to the old school hemiarthroplasty. And in some cases, you can't get fixation. This is just kind of showing a schematic of how to do a reverse shoulder, but the idea is the same. You want to put a fracture stem into the bone, but the soft tissues are the most important part. So you want to have heavy sutures into the substance of the tendons. And this is why when we do therapy afterwards, these muscle tendon units that have bone attached have to heal. So usually we will hold up a fracture patient for 4 to 6 weeks to allow that bone to heal back. So once you've got that implant in, you're going to bring the greater tuberosity around, and that's what we're protecting. So having an extreme amount of external rotation, you know, is probably not what you want early on. You probably want to have a little bit of scaption in the forward plane once you start motion, and really no heavy lifting. But this is a huge, huge operation in terms of suture management. So when you do this, you're doing what we call horizontal fixation that you just saw, and vertical fixation, where you actually can fix the tuberosities down. So they're going to be stiff in external rotation coming out of the block once you get them into therapy, and they're going to gradually work on that. The nice thing is, with the reverse shoulder, the recovery is much faster than with the traditional shoulder arthroplasty. So in conclusion, I think you want to mobilize the tuberosities with heavy sutures, avoid a biceps tenodesis in a forepart, use K-wires to maintain reduction, structural graft, and then you want to get this tuberosity reduced. And as a therapist or as any other allied professional that's working with these patients, you want to take it slow with the strengthening until the bone heals. And the bone will heal between 6 and 10 weeks, so we can count on that. So I think that if we look at this, and what I want you to take away is that when I get sent that patient that's demented, that's 92 from the nursing home with a proximal humerus fracture, that's somebody who can stay at the nursing home and get a sling and some conservative care. I mean, I'm starting to get these patients that no one is going to operate on these folks. The other thing that I found interesting, and I'll end this on this, I had a patient yesterday. Here's the other hard part. These patients come to us, whether it's Dr. Gasser or Dr. Baker, they've broken their proximal humerus. The lady yesterday was hiking on the Appalachian Trail. She fell down. She got 2 minutes in the ER and waited 5 hours to be seen to get a sling, because that's all we give them. And they go, I had to wait 5 hours to get a sling. So the only thing I can tell you, when you sit down, you got to spend a little bit more time with them, because I've had about 10 patients now in the last 2 months come to me because they go, I went into so-and-so's office. He said, yeah, you got a proximal humerus fracture. Here's a sling. I'll see you in 3 weeks. So when you get those patients, I kind of, oh, that's really bruised. That must really hurt. I mean, spend a little bit more time with them, because I'm getting a lot of bounce backs. And just tell them how much because it does hurt. But as an orthopedic surgeon, if we see a non-displaced fracture, we're moving on to our next patient. So that's the patient we need to sit down and talk with. This lady actually was so frustrated, she went out to some orthopedic warehouse and came in with no less than 6 different immobilizers and asked me which one I liked the best. And she went through this little bag and brought out the sling and swath, the immobilizer, the pillow, and I'm like, and I listened to her, and then I took her back in we have a little cast room and let our orthopedic tech spend another 20 minutes with her, and she left happy. And at the end of the day, we want to have people leaving our office happy and feeling like they really got the care that they deserved. Anyhow, I hope you enjoyed the talk, and have a great day.